other imaging studies are ordered. When examining gastrointestinal tract by X-ray, the patients usually have contrast of which one? Barium per os or rectum.
Both we can use.
So why to recognize abnormal findings on conventional radiographs of the abdomen, you must familiarize yourself with the appearance of normal first. So let's go to the X-ray projections. As in chest X-ray, here again we have posterior, anterior, anterior, posterior. But here we have supine images mostly. For abdominal X-rays, we do X-ray in a supine position and not in a upright or standing position. So standard projections, anterior, posterior, supine view can be performed as a standalone projection or as part of an acute abdominal series. Posterior, anterior, erect view often taken with the supine view. When used together, it is a valuable projection in assessing gas fluid levels and free gas in the abdominal cavity. Then we have KUB view, which is kidney, uterus, and bladder view. That is used to visualize calculi within the urinary system. And then again, we have lateral decubitous, lateral view, and so on. So abdominal X-rays will to look for. First, look at the overall gas pattern. You are looking for the overall pattern, so do not spend too much to trying to identify every bubble of gas you see. Then second, look at the extra-laminar layer. Also look for the abnormal calcification. For this point, what do you think? Do you need contrast injection or contrast administration or no?
Calcification,
No need.
So you should always have X-ray image without and with if there is a need to do contrast examination. So fourth, look for any soft tissue masses. Now, is this normal?
Yes.
No.
Why?
Yes.
Why
This is
that's
normal.
why?
This is normal. This is from intestine. We are having that one, right?
In this,
That is normal.
normal.
And that is stomach on that side, right?
That's the stomach.
On which side? On which side?
Left side.
Left side.
So virtually all gas in the bowel comes from the swallowed air. Only a fraction comes from the bacterial fermentation of food. And in the abdomen, the terms gas and air are used interchangeably to refer to the contents of the bowel. So loops of the bowel that contain sufficient amount of air to fill the lumen completely are said to be distended and not dilated. Distension of the bowel is normal. So loops of the bowel that are filled beyond their normal size are said to be dilated. And dilation of the bowel is abnormal. So, anyways. It's visible. So in stomach, there is almost always air
Yes.
in the stomach, unless
When we eat
Digestion.
food
After
is
food.
food storage. Yeah?
After food.
Whenever food is stored, unless while eating, I guess. While eating.
unless there is nasogastric tube attached to the suction, and also if the patient has recently vomited. So in the small bowel, there is usually a small amount of air in about 2 or 3 groups of non-dilated small bowel. And the normal diameter of the small bowel is usually less than 2.5 centimeters, which is about 1 inch, but I don't think you use inch. Large bowel, there is almost always air in the rectum or sigmoid colon, and there may be varying amounts of gas in the remainder of the colon. So use the rule to decide if the large bowel is dilated or not. If the large bowel can normally distend to about the same size as it does on a perium enema examination, then it is not dilated. So here you can see. And remember also 369 rule. 3 for small bowels, 3 centimeters. 6 for rectum, and 9 for
Last
cecum.
one.
If more, then there is dilation. Which one is normal?
Normal.
This one? This one?
कौन सी नॉर्मल आप मिडल ऑर्डर नो नॉर्मल like this.
This is middle one is lateral. No.
The middle one is called aerophagia. When the patient swallows too much air, that is the aerophagia. What is the first one?
Fluid
Actually, that is just stool. So stool is recognizable by the multiple small bubbles. Present within semi-solid appearing mass, as you can see in this first case. So recognizing the appearance of stool will help in localizing the large bowel. And individuals who swallow large quantities of air may develop aerophagia, which is characterized by numerous polygon-shaped air-containing loops of bowel, none of which are dilated. And the last one, you can see air in the stomach, and there is almost always air, and you will see air fluid horizontal level in the stomach. How to differentiate large bowel from small bowel?
House stress is present. House stress is large and
What else?
maybe because of size or the location.
size.
No.
Maybe the small bowels will be dilated and you will not be able to differentiate by the size. The location. The large bowel is located peripherally around the
location
perimeter of the abdominal
Middle.
cavity, except for the right. Right upper quadrant.
It is behind.
Behind the liver. Also, rostral markings usually do not extend completely across the large bowel from one wall to the another. While in the small bowel, you will see. What you'll see instead of ostrus.
There is also
Valvular markings, and those extend from one wall to another wall. Valvular markings. And also the valvulae are spaced much more closer together than the post-eruptive large bowel, and you can differentiate just by their distribution. If those are closer to each other, then probably it is small bowel, and if those are further farther from each other, then it is large bowel. Now, acute abdominal series, the views and what they show. Almost every department of radiology has a series of radiologic images of a protocol that are routinely obtained in patients who have acute abdominal pain. And these series are sometimes called obstruction series or complete abdominal series or acute abdominal series or something similar. For the purposes to understand what to look for in the acute abdominal series, we'll go through the positions first of all. So what it's good for and why do we need to take this view? So supine view, overall appearance of gas pattern, then the overall appearance of the bowel gas pattern, including how much air and fluid there are, and their most likely locations is more important than identifying every small bubble of air on the radiograph. So identifying the presence or absence of calcifications, then identifying the presence of soft tissue masses and how it is obtained. The patient lies on his or her back on the X-ray table or stretcher, and the X-ray beam is directed vertically downward, and the detector is behind the patient. Next, we have prone view. What is good for identifying again gas in the rectum or sigmoid colon. Why? Why not overall gas pattern, but only rectal or sigmoid?
Posterior.
Because the rectum and sigmoid are posteriorly located, and when the patient is lying on his abdomen, the air will go up
Towards.
So because the rectum and sigmoid colon are the highest points of the large bowel, and the person is lying on prone on X-ray table, air will rise into the rectosigmoid colon, and almost no air is introduced into the rectosigmoid colon during the course of a routine rectal examination. So identifying gas in the ascending and descending colon, also prone view helps because these two parts of the large bowel, in addition to the rectosigmoid colon, are also posteriorly, and air will collect in them when the patient is lying prone. Then we have lateral rectal view. The patient is lying on his or her left side, and thus lateral view of the rectum can be exposed with a vertical beam to substitute for the prone radiograph. The lateral view of the rectum will usually demonstrate the presence or absence of air in the rectum and or sigmoid colon. When you should think that there is something acute, just by looking for gas pattern, where you should see abnormal gas or air when you look on X-rays, and when it will be acute condition.
Small bowel.
Extralaminar air. Why? Because of perforation of the bowel or stomach or something. There is perforation when the air will
Outside.
outside of the lumen, and it will appear in the abdominal cavity as a free extralaminar air. It needs to be cleared. So upright view of the abdomen, what it's good for.
abdomen, stomach, or
Hmm?
right.
Free air.
Mm.
Would you be able to see free air when in supine position? The patient is in supine position. No. Why? Because it will overlap with the air or gas in the bowels. While in the upright position, the air will go up and it will be visible between liver and diaphragm. Okay. So calcifications, most of tissue calcifications occurs in tissues that are already abnormal. Such calcification is called dystrophic calcification, and the nature of most calcifications can be determined by examining two of their characteristics. First is their pattern of calcification and their anatomic location. So, rim-like calcifications usually appear in the wall of a hollow viscous, linear or track-like calcifications in the walls of tubular structures, lamellar or laminar around the nidus inside the hollow lamella, and cloud-like amorphous or popcorn inside of a solid organ or tumor. Popcorn calcifications are, and it is not only for lungs.
Mm-hmm.
So rim-like calcifications imply calcification that has occurred in the wall of a hollow viscous. A hollow viscous in this context means a structure containing fluid, fat, or air, and enclosed by an outer wall. So examples of structures that manifest rim-like calcifications include cysts. Calcification in any one of these is relatively uncommon. Then we have renal cysts, splenic cysts, extra-abdominal sites such as mediastinal cysts such as pericardial and bronchial cysts, and calcifications in the cysts is very uncommon. Then we have aortic aneurysm, which can be sometimes recognized on lateral radiographs of the lumbar spine. And the abdominal aorta should normally be less than 3 centimeters in diameter. Measurement that requires both opposing walls be visible. Then we have also splenic artery or renal artery aneurysms that may be calcified, and also some sacral organs such as the gallbladder or urinary bladder may contain calcifications. What can you see abnormal on this?
This gallbladder. This is gallbladder.
Which one? This one?
Yes.
Okay.
And this.
And what is this? What structures do we have here?
Stomach. No, stomach should be on this side. Small intestine.
Remember that the X-ray image is overlapped image, so it's not just one
So kidney should be there, right?
slice.
That's all. खाली
Pancreas.
असेल kidney better खाली
What do
असेल.
we have near the vertebra?
Kidney.
Pancreas.
Kidney असेल ना kidney. Kidney. Back side ना? Spleen
What
पे
is
back.
this?
Sacromegaly will be born.
This one is vertebral for sure.
Spleen राहिला मग दुसरं काढलं तरी काय?
Spleen would be somewhere.
Large intestine.
Organ.
No.
Large intestine. Part direct.
Aorta.
अच्छा गावात abdominal aorta आहे. How find now.
What is this?
That you
If this one is aorta, what is this?
Esophagus. ಅಲ್ಲ,
Oh, ureter
not
also there.
esophagus,
Ureter, no?
this ಇದು inferior vena cava.
Ureter.
Inferior vena cava is
Behind.
That veins.
Behind
Superior
and
mesenteric
behind.
and that mesenteric
to
vein.
the right or to the left?
To
The
the
S,
left. No, to the right.
And where you find that aorta, abdominal aorta? Can you show?
Huh?
Abdominal aorta.
Yeah, this one.
Okay.
This is the calcified abdominal aorta.
Oh,
It should be straight. No? So
But this one is dilated annulus spinalis.
So due to it will be shifted. What is a actual aorta?
What is this? And this.
That vein superior
ureter.
superior mesenteric and the vein as well.
Iliac vein. Iliac.
Hmm?
Common iliac. ಅಲ್ಲ
Internal.
iliac veins.
Lumbar. सगळं सांगितलं.
It's not a vessel.
Aorta splits. Oh,
Ureter
it's
veins.
down.
किडनीची युरिन राहतात का ते कटे बेसिकच आहेत काय
Psoas muscles. Okay, so in the first image we have calcification in the wall of the abdominal aorta, which is a common finding in atherosclerosis, especially in those with diabetes. And in this patient, the aorta demonstrates a rim-like calcification. And this one is
Gallbladder.
तो तो बोलते हैं कौन सी की पीठ कर दी पीठ छोड़ी
now linear tract-like calcifications usually appear in arteries and tubular structures. Common in atherosclerosis again and seen anywhere in the body. Walls of veins. Can you see calcification in the veins?
what
Calcification in the veins.
आता मगाशी बोलतो yes we saw in veins veins म्हणजे काय veins काय but you saw
Veins, the walls of the veins do not calcify. In veins, usually you can see long linear thrombi or small focal thrombi, but not calcification of the wall. What can be calcified in the vein?
Valves.
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 ma'am told valves cannot be
No, she told veins cannot be calcified. Walls of the veins.
Walls of the veins. But what can be calcified?
like valves
Valve,
valves
valve.
valves what valves nice but valves नसतं ते त्याला
Thrombi.
अच्छा
Oh, thrombi like it's not.
And that is called
That is called
flabellate.
What?
Flabellate. Sorry guys.
Flap.
चंगा आवाज में हम कहते हैं एक मिनट
walls of the veins. Thrombi, which thrombus is formed in veins.
Then we may have tubular structures that are calcified, linear or tract-like, and that is seen more often in diabetes. Ureter can be also calcified, linear and tract-like. Uncommon finding seen in schistosomiasis and even more rarely in tuberculosis. What can you say abnormal?
this are
Something
ureters
is
What is
calcified.
this?
Kevin sa bone mein on this we can see ureters no on this two
On this?
this two are ureters
Okay.
right
Okay.
Ureter is calcified.
Okay, now this picture. Oh. It's coming from up to
Which
down.
part is that one? What's the
This is the leg.
What is it?
Leg.
like femoral artery.
Amputation. Knee amputation.
Femoral artery. Femoral artery is calcified.
तो leg होता एक से एक से
What is this?
Femur.
friends.
What else can be this one? If not urethra.
If it is male, so ते काय बोलतात मेल मध्ये काय असतं अरे काय बोलतात मेल मध्ये
काय डिफरन्स असतो
अरे नाही मेल मध्ये काय बोलतात eventually? तुझ्या आंडीला धरायला काय असते असे चालू आहे
Over it.
Difference.
हां बघ वास्ट डिफरन्स म्हणतात शब्द जाऊ दे तुला बरोबर म्हटलं ना ते धरायला काय असते
Now, lamellar or laminar calcifications are usually called stones or calculi,
कैसा
and
मैंने इसको
they
मराठी शब्द
include,
बताया था पकड़ने के
renal
लिए
calculi on computed tomography.
तू पण विचारना है
Actually, computed tomography is the study of choice for the detection of renal and urethral calculi. Conventional radiographs are only about 50% to 60% sensitive to display renal calculi, despite the fact that about 90% of renal calculi contain calcium. And gallstones are also lamellar or laminar type of calcifications, and only about 10% to 15% of gallstones contain enough calcification to be visible on X-rays or CT scans. What examination should we do to identify the gallstones that are not containing calcium?
अल्ट्रासाउंड
Yeah.
because we study topography
That's it. What else?
what else CT okay what doctor has sent to sonography
Bladder stones usually develop secondary to chronic bladder outlet obstruction, and they are very prone to develop lamination. So what can you see in the first image?
kidney stone this is the
Where?
कुठे माहित केलं नाही ते नाही no Kevin that is not I guess tell Kevin what is that one that white
That is the stone, no?
that is stone na
Stone, no?
Stone. Yeah, where? Left.
kidney में stone है तो
Can you see the outline of the kidney?
Yes.
Why?
हो air असो kidney
Because it is surrounded by air.
मग air असणार आहे म्हणून दिसणार आहे दुसरं काय
What can you see in this?
again stone that white
First of all, what type of examination is this?
CT
CT.
CT
Which projection?
axial
Axon
Okay.
projection.
Which view?
bow no which
Superior.
which view
Which abdomen?
Form,
Which
no?
window, sorry.
that
Which
one
window?
bone
Soft-
bone no?
Soft
Bone?
tissue.
Soft tissue.
Soft tissue.
bone तो white white दिसत आहे
What can you see?
Stones.
that stone this here also and here also bilateral
Bilateral, okay.
bilateral stone
Where?
These two is kidneys, no?
bilateral
This
stone
one is kidney. This one is not kidney.
That's urine.
that ureter मध्ये आहे वाटतं तू that is ureter that is in ureter no
Yeah. In the right side, we have in the proximal part of the ureter,
Hmm.
and on the left, in the
In the
kidney
Mm.
Okay. What can you see on X-ray image?
So many gallstones.
On CT image, but with soft tissue window.
here we can see that below to the
This
liver
is
canal.
also gallstones.
Yes,
Mm-hmm.
because
Middle
that
one.
is liver one.
Liver.
And in bone window.
This one,
In bone window.
what is this? Where is one? हे काय आहे? खूपच मोठं आहे रे. And which part is that?
You tell me.
Tell me.
What is this?
काय पेड ऑर्गन आहे काहीतरी.
This one is bone window.
Mhm.
What is this?
अरे प्युअर नाही बोन ऑर्गन. काहीतरी पेड आहे रे. पेड ऑर्गन दोन्ही कडे सेम दिसत आहे.
Pelvis bones.
Mhm.
And which part is this?
युरिनरी ब्लॅडर राहिला तर ब्लॅडर राहिला.
Urinary bladder.
ब्लॅडर ना हां बघ
And
दोन्ही
bladder
कडे.
stones. Then we have cloud-like amorphous popcorn
Because in between
calcifications.
pelvis what you have ब्लॅडर only.
Those will appear mostly inside of a solid organ or a tumor, and examples include body of the pancreas, and that is pathognomonic for chronic pancreatitis, leiomyomas of uterus, uterine fibroids, or leiomyomas very commonly degenerate and calcify over time, and also lymph nodes may be calcified anywhere in the body, mostly the result of prior granulomatous infections such as old tuberculosis. In kidneys, medullary nephrocalcinosis is macroscopic calcification deposited in the pyramids of the renal medulla, and usually secondary to metabolic derangements such as hyperparathyroidism or something else. What is abnormal on the first image?
कोणती गोष्ट आहे? One by one.
Popcorn calcifications.
कशात दिसते पॉपकॉर्न
Where?
It's all popcorn.
Hmm?
No.
What is this? Mm-hmm. Liver. Maybe. Maybe breast shadow. Why not?
It's not breast.
Okay, what is this?
Pancreas.
That is pancreas calcification. On CT image, what can you see?
ती लिव्हर आहे इकडे काय राहिली लिव्हरच्या पुढे. This is from like this. Pancreas नाही.
Pancreas. On this one.
This is popcorn I guess.
Ma'am,
Huh?
see this pancreas?
Yeah.
This long one.
This one.
That white thing.
This one? This is stomach.
Air है stomach inside of the stomach we are air air.
Hair.
Food.
That one why don't this is अलीकडे.
What is this one?
Which one?
This one.
That is popcorn no?
Where?
Popcorn.
Bladder.
Above the bladder. हा तर बोन आहे आपलं पेलिक्स असं वरती गेला.
No.
पण मेलचा पार्ट बोलतच नाही आता सगळे फिमेलच
Uterus.
Uterine leiomyoma.
व्हॉट व्हॉट
Uterine leiomyoma.
अच्छा गावात बट हाऊ यू अंडरस्टँड हाऊ मॅम हाऊ टू अंडरस्टँड इट इज
By the
युटरस
location.
बट मेल फिमेल तर समजतच नाही. हा दिस
pelvic wall.
बोन येस
And if the patient has something like popcorn or something. Calcifications. Just by shape of the calcifications, by location, you should just think about whether there may be calcification of leiomyoma or something else, and you should just figure out what causes
मेल फीमेल समझत नहीं है
what can
one picture left back
this one again.
see
Uterus.
what is popcorn shape is
Flagellate.
Thrombus.
Veins,
Calcification of
calcification.
thrombus in veins.
Veins of
Rib.
thrombus calcifications. And calcifications also may
Rib
be
cartilage.
rib cartilage.
cancer शिकवत नाही but first PPT is you did not study first PPT no after first PPT of abdomen 10th one